Thank you, Miltos, for inviting me here and for the nice presentation that you made. So I'm going to talk about preoperative assessment of traumatic cataract, things that you should not miss, but also have some clinical cases during the surgeries that in different situations have to be will be presented. My first question is, how many of you do work in an emergency eye department? Some of them, but less than 30%, I would say, because I'm not working in an emergency eye department. So most of my cases are cases with trauma, but they went to the local doctor and did the emergency things to be done, and they come to me with cataract and other issues, but let's say in a chronic manner. So the history is very important. As I mentioned earlier, I will not stay anymore on this subject. Very important also which type of trauma. Was it direct, indirect, perforating? Miltos showed so many things of etiology, but honestly, in the real life, most of the cases are with physical trauma, either blunt or penetrating, perforating. And what should you look for when you prepare for the cataract surgery? Biometry is very important. Unfortunately, it's not the topic and not, but it's very important. Sometimes, for example, when you have corneal wound, it's a mess and you cannot rely. You can rely only maybe on the other eye, or you can just postpone the implantation of the IOL when you are not sure. The eye examination, a thorough eye examination is very important, and as I mentioned, the UBM, anterior segmentosity, B-scan, RX, everything can be helpful when you have some doubts. And an eye injury can affect any structure of the eye, either in present or in the future, and we should warn the patient about this. He or she comes to me with cataract, but with a stable, let's say, posterior segment, and I do my best. I resolve very well the cataract and the IOL implantation, and after 1 month, he or she develops a retinal detachment. It's not because I didn't do a good job. It's not because his fault. It's because of his old, long-standing, let's say, post-traumatic status. The vitreous was more or less in an equilibrium fashion, let's say, and with my surgery, also a good surgery, I disturb this equilibrium, and maybe I can get in favor of the retinal detachment. Also, the secondary glaucoma is very frequent in traumatic eyes, so we need to prepare the patient for these possibilities. What should we look for when we prepare the patient for the cataract surgery? Is the lens subluxated or is it zonule, dehiscent? If yes, how much is it? Other corneal wounds, suture or not, long-standing or not, maybe already leucomas or corneal erosions. Is there vitreous in the anterior chamber? You can assess it either clinical or with UBM. Is the anterior capsule puncture? Is it the posterior? Can you see it? Can you be sure? You can never be sure, as Miltos just mentioned, and you should be prepared for being already punctured. Is it iris involved? Do you have synechia, anterior or posterior? Do you have traumatic mydriasis, sphincter ruptures, iris coloboma, iridodialysis? Any of these concurrent pathologies may change the planning and the surgical technique, and you should be prepared for all of them. Let's start with a situation which is most frequent, a blunt trauma with traumatic cataract with subluxated lens. I perform more or less standard phacoemulsification. After I put 2 iris hooks on the CCC. Low parameters, but not very low, as you see. This is what I do because I found the bag very stable. But anyway, hydrodetection is very important. You don't want to rotate the pupil without a proper hydrodetection because you don't want to enlarge the damage. So if you end up with a stable zonal dialysis that you had at the beginning, you can just implant on CTR, no suture, but you can assess according to the length of the rupture of the zonules. In this case, a simple CTR was okay. You can choose to make, of course, if it's necessary, you do a minimal local anterior vitrectomy, and this is how the eye looked both without and with mydriasis few days post-op. This is a second case in which I had a larger, so preoperative that it was a larger zonular dialysis, and the cataract was mature, and I assumed that maybe at the end I needed to, my zonular dialysis would be larger and I might need to withdraw the bag. When you decide to do this, please pay attention not to have remnants of cortex, because when you withdraw the bag and there are some cortex inside, it will rotate, and some of the cortex will remain in the anterior chamber or even behind the iris, and you need to check for it and to be sure that you clean everything with vitrectomy. I choose in this case acrylic suture with Gore-Tex. It's my preferred technique in cases with no capsular support, and this is how the eye looked post-operatively, few days post-op. And
so
this is.
You are a Calabrava lover, and you like the technique of Calabrava?
No, I use Gore-Tex suture, very, very stable. Okay. So Gore-Tex instead of Calabrava. Sometimes I do Calabrava, but Gore-Tex.
All of the VR surgeons are allowed to use Gore-Tex sutures. I don't know why. I don't know.
It's very stable. I had cases when they had a serious trauma after my, let's say, acrylic suture with Gore-Tex. The iris was out, but my lens was perfectly in the axis and remained. And it was the Gore-Tex is for life. Let's not forget the old-fashioned intracapsular technique. Sometimes it might help you, like in this case. So this is 84 years old male or 87 with 900 endothelial cell count and with a large zonular dialysis, post-traumatic. I decided from the beginning to perform intracapsular. Of course, I started with anterior vitrectomy in the area where the zonule was ruptured. And yeah, you should know this technique. It's old-fashioned, but it's sometimes very, very helpful. Okay, this is just to show that sometimes you can use, when you're not sure that everything is clean inside, you should use triamcinolone to be sure that you clean everything, the back, the anterior chamber, the retro, the space behind the iris, everything. And another case, this is a situation with a long-standing after-trauma status, with a penetrating trauma at that time, with eye perforation, anterior capsule was punctured, and the cataract was partially resorbed. You can see here mostly cortex, which became very tough, very hard, and you need to treat it step by step with low parameters. Yeah, my vacuum is it's in rising and then getting down fashion, and then in this case, I remain with thick opacification of the capsule, of the posterior capsule. I expect it to be stuck together with the posterior capsule. I cut it with the VR scissors, very, very careful. And the good surprise was that the capsule was absolutely intact. So I managed to detach it with viscoelastic and with small and very careful motions to detach it completely and to implant PCIOL in sulcus, 3 pieces.
That is excellent surgery. Very well managed, and it's a difficult problem, because you have materials that you have to use phaco, you have to use all your tricks in order to get rid of all this whitish tissue and maintain the capsule to insert the lens. Excellent,
yeah,
excellent.
Yeah. Thank you. So this is another case, long-standing cataract in a lady. I perform UBA. You can see here the partially resorbed IOL cataract. It's a brown, tough, hard cataract. I perform the anterior vitrectomy, and then, of course, in this case, I choose again to perform intracapsular. Again, very careful movement, using OVD behind the lens and in front of the lens to protect your cornea, and look how black and tough the cataract was. This is a video from maybe almost 10 years ago. At that time I used, especially in cases with large incision intracapsular, I used PMMA eye with eyelets on the haptics and Prolin suture. This is what I did here, and this is how the eye looked a few days after surgery. And this is a case with penetrating trauma at the limbus. You saw the pupil, the ectopic pupil, and some iris coloboma, but this patient also had retinal detachment. So I perform a standard, more or less standard phacoemulsification. I treated the retinal detachment, and I just leave the patient like this, because my first attempt was to attach the retina and to see how it is working. And then if the patient complains because his pupil is still ectopic, I can do something about it. I would say more some diathermy to enlarge the pupil towards its center. This is another case with associated coloboma, white cataract. Of course, I used the dye. In this case, you don't see the coloboma is here. It's 5, 6 o'clock, but you will see it after I constrict the pupil, the chop technique, my standard technique for advanced and mature cataracts, or quick chop technique. Anyway, you can see the parameters in the right part of the screen. The cataract went very well. I implanted the 3 pieces IOL just to be sure that it will stay well centered and with optic capture. And here you can see the coloboma, and I performed the standard, I put 2 sutures, 10-0 double-armed Prolani sutures with Sipser knot, 5 times around the longer part of the loop. And this is the first suture, but at the end I had 2 sutures, as you can see here. The pupil without mydriatics, with mydriatics, there is an opacification of a posterior capsule, which I will treat it with YAG laser, should it be the case. And the last situation is a blunt trauma with associated iris dialysis. Very important to put iris hooks on the dialysis. This iris rupture is very floppy, and you can catch it with the tip of the phacoemulsification, so it's very good to stabilize it with 1 or 2 hooks, depending on its length, and performing standard phaco and implantation of the IOL in the bag. Then what I do, I suture the iridodialysis. I perform here 2 scleral grooves at 1.5 millimeters from the limbus, in which I entered with angled 26 or 30 gauge bent angled needle, which will coat my 10-0 double-armed Prolani suture.
Here also is very interesting. You can use the sewing machine technique. I don't know whether if you're familiar with that. You just put your needle, and then you just arm your material, your 10-0 Prolani and the needle. The needle should be an insulin syringe, but a big insulin syringe, not the small one, the large ones. And then you create an incision on the other side, about 1 millimeter away from your limbus. And what you do is that from the opposite side, you push in, out, just like a sewing machine. Yes. And you have... I will show it. You show it.
Yeah, it will be in the Ahmed presentation, yeah. Just as a tip and trick, you should aim to catch the...
didn't tell me. I spent half an hour to explain it.
Okay, just a tip, let's say. Yeah. You should catch the iris, the ruptured iris, as in peripheral as possible. Otherwise, you will finish with the iris, with a deformed pupil. Here it is very, very small, but there are cases where you can see even a more deformed ovalization of the pupil. This is a case, I have only pictures here. You can imagine this is pre-op. This is at the beginning of the iridosutures. I already did the cataract under iris hooks implanted in IOL, and I did the same in the same manner. I sutured the iris, and this is how it looked at, I don't know, maybe 1 week post-op. In conclusion, traumatic cataracts are usually challenging cases, presenting with different clinical situations. A thorough examination before the surgery is mandatory. Be prepared for several maneuvers needed to be added to the cataract removal itself. Anterior vitrectomy, different types of iris sutures, CTR or CTS sutured at sclera, different types of implantation or sutures of different IOLs in the absence of the capsular support. You can use, apart from what I have as a preferred technique, acryosutural sclera with Doretex, you can use Yamane, Garvald, Chariot, Canabrava techniques, Carlevale IOL, or iris suture fixation, iris claw, anterior retropupillary. Some of these cases I also performed in other cases. And don't forget, old-fashioned intracapsular extraction can be still valuable in some traumatic cases, as you just saw. Thank you very much.
Thank you very much. Thank you very much, Ozana.